Now we'll move to Dr. Tamer Fekrey. He will talk about hostile carbon dioxide angioplasty new invention.
السلام عليكم ورحمة الله. في البداية طبعا أحب أشكر أستاذ الدكتور مسعد سليمان على المؤتمر الفاخر اللي استضافنا فيه. The second thing أنا عايز الحقيقة أدعو بالمغفرة لأستاذنا الدكتور محمود صبحي اللي وفاته المنية من فترة قريبة. والحاجة التانية ندعي بقى لإخواتنا في فلسطين في غزة وفي لبنان إن ربنا يزيح عنهم الغمة إن شاء الله. So I will start my presentation about the literature. Many literatures and studies and papers have mentioned the carbon dioxide, talking about its scientific principles and its use as an intravascular contrast medium. So in history, CO2 use was started in 1920s for visualization of retroperitoneal structures. In 1950s and 60s, it was injected intravenously to visualize the pericardial effusion into the right atrium. And this imaging technique developed from animal and clinical studies which demonstrated that CO2 is very safe and well tolerated. And with the advent of DSA in 1980s, it was the evolution of the CO2 use. And CO2, regarding its properties, it constitutes about 0.03% of air and is treated as if it is partial pressure were zero. And the density and the atomic weight of the substance compared to body tissues classify contrast medium into positive and negative. So CO2 is considered as a negative contrast agent. And of course, the advent of DSA technique gives its properties as a contrast resolution. CO2 is 28 times more soluble than oxygen and 54 times more soluble than nitrogen. And this high solubility allows the injection into the arteries below the diaphragm and veins without clinically significant gas embolism. About 5 milliliters of CO2 trapped in the right atrium will dissolve in nearly 45 seconds. CO2 bubble in the pulmonary outflow tract following an intravenous injection will disappear in 15 seconds. Multiple CO2 injections are to be made. If are to be made, the time interval between the injection should be increased to 3 to 5 minutes, especially in case of emphysema and pulmonary hypertension. And here is a comparison between the CO2 and iodinated contrast agent. And of course, you can see about the nephrotoxicity and the allergic reaction, and of course the cost. And of course, it has some limitations. The advantage, of course, it's regarding the renal toxicity and anaphylaxis, which is not present in cases of CO2 injection. And CO2 is eliminated from the lung in single pass. Unlimited volume of CO2 can be used with injection should be separated by 2 to 3 minutes. And because of low viscosity, CO2 can be injected through a microcatheter, skinny needles, and between the catheter and guide wires, and even from side port of a stent delivery system. CO2 has been effective in visualizing lower extremity arteries, tumor vessels, arteriovenous fistulae, and visceral arteries. It is very sensitive in detecting the gastrointestinal and traumatic bleeding. It is safe and effective flushing medium for catheter and sheaths. Disadvantages, CO2 requires a special delivery system, catheter properly, to prevent air contamination and gas compression. CO2 shouldn't be used as a contrast agent in cases if you would like to, because it has a neurotoxicity effect and myocardial ischemia, so it's not advised to inject it into above the diaphragm and into cerebral circulation. It's contraindicated as in thoracic aortography, coronary arteriography, and cerebral arteriography. It shouldn't be injected into the abdominal aorta in prone position since it's a buoyant gas, so it has the ability to go upside or upward. So, and of course, in prone position, it will go to the spinal and lumbar arteries and may cause spinal cord ischemia. CO2 shouldn't be injected into the abdominal aorta with patient's head in elevated position because it can go up as well. Relative contraindications include pulmonary hypertension and the chronic obstructive pulmonary disease. CO2 should be used continuously in patients with patent foramen, cautiously in patients with foramen ovale or atrial septal defect. The imaging of CO2 has been improved much with the use of digital subtraction equipment, and with the innovation of the stacking software, you can integrate a lot of pictures of CO2 into one single powerful improved image quality, like what we can see in here. This is with the use of a stacking program or stacking software. In case of AAA, for example, if trapped CO2 is seen in ventral portion of AAA, the body position should be changed from side to side to wash out the gas. When compressed gas exits from the catheter, there will be expansion of the gas known as explosive delivery that may cause discomfort to the patient. That's why most of cases I used to do it with the spinal anesthesia. Clearing the fluid or blood of the catheter with an injection of 3 to 5 milliliter of CO2 decreases gas compression and expansion. CO2 can provide much of necessary visualization information for safe deployment of aortic stent graft, and it's also very useful in diagnosis of endo leaks without using of contrast agent. But if you think you are unsafe, just inject a very minimal amount. After placing the main body endograft, 20 milliliter of CO2 injection through the side port to identify the orifices of the renal arteries with the side elevation of the table to 8 to 10 degrees to see the renal arteries in a good quality. Hypogastric arteries can be identified with injection of 20 milliliter of CO2 through the femoral sheath. And of course, completion angiography is enough with CO2, but you can use a minimal amount of dye. Here is a case of CO2 Chivar of a 76 renal patient, hypertensive with AAA and impaired renal functions. Here is the AAA, CT without contrast. And here is the MRA. We started our procedure with diagnostic with CO2, and we go from upside to cannulate the right renal artery because it has a short neck, so we have to cover to do a chimney. And we continue our procedure as usual. We inserted the stent, and we started with the main body, and we now taking another CO2 angiography. We placed the stent, the renal stents, and we started to open the body, and everything went okay, and we didn't need a single centimeter of or milliliter of contrast agent. And here's post-completion CO2 angiography. We all use CO2 with this catheter actually, and one end of the catheter is connected to the machine of the CO2 device that the engineer used to do it, and the other end is connected to the sheath, and we use it to inject the CO2. But we face difficulties actually in the availability of CO2 at many times, and the cost of CO2 catheter now in Egypt is very high. I don't know why actually. The alternative is to give the patient iodinated contrast agent with the risk of developing renal toxicity and renal impaired patients. Is there anything we can do? Actually, we go back to the literature and we found that they already mentioned it, and we are now back to the future. Actually, this diagram was written or was mentioned in one of the studies and papers. All you need is a reservoir bag to collect CO2, pure CO2, and to make a system which is completely sealed with closed circuit, and you inject the CO2 from this syringe to the patient. So we used the CO2 cylinder that is used for laparoscopes, and this is our reservoir bag, the fully catheter bag or the urinary catheter bag. We can also use the blood collection bag, all you need is to collect through, from the cylinder to this reservoir and to take from this to the patient. And this is not actually a new technique. And here is a video illustrating this connection. And the quality is nearly the same like the machine used for injection of CO2. And of course, before I end, I just invite you all to the EVES Summit, the first one to be held at the end of this month. Thank you.